Hello, my name is Dr. Granzow. Today I'll be reviewing the National Lymphedema Network position paper on lymphedema surgery. I'll review some of the key points and provide some illustrations, and I'll review commonly performed lymphedema surgeries. Key points. Surgery to treat lymphedema is well established and it's not experimental. When performed appropriately in carefully selected patients, lymphedema surgery is effective in treating lymphedema. Here's an example of the effectiveness of lymphedema surgery. This patient has a history of congenital lymphedema, means she was born with the disorder, and this affected obviously her left leg. 1 year after debulking surgery, which is a SAPL surgery, this is her result, and here's the result from the opposite side. It's important to note that lymphedema surgery complements, but it does not replace, conservative lymphedema therapy. The conservative lymphedema therapy remains the cornerstone of lymphedema treatment. Multidisciplinary collaboration, careful patient selection, and adherence to postoperative care protocols are essential to achieving best outcomes. This is a team-based approach, and a team-based approach at an experienced center can provide great surgical outcomes. Again, the therapy portion is essential for good outcomes with lymphedema surgery. Patients must understand that there is no cure for lymphedema. In fact, to be a candidate for lymphedema surgery, patients must have optimized conservative lymphedema therapy before surgery, and patients must also be willing to continue lymphedema therapy as needed after surgery to the extent required by their individual lymphedema situation. Additional key points from the position paper include that improvements from lymphedema surgery include significant limb volume reductions, decreased complications such as infections and cellulitis, and enhanced overall quality of life. It's very important to understand that different surgeons and different centers may have different protocols and surgeries and treatment methods. Here's some data from my clinical practice. This mirrors that found elsewhere in the medical literature. Overall, we find tremendous reductions in the incidence of cellulitis, which can be very dangerous in lymphedema patients. This is one of the most dramatic health benefits of lymphedema surgery. To be a candidate for lymphedema surgery, and before a recommendation for surgery is made, the diagnosis of lymphedema should be confirmed by objective lymphatic imaging studies. These include lymphoscintigraphy, indocyanine green imaging, and perhaps ultrasound or MRI. One of these studies as an objective measure is sufficient to confirm the diagnosis of lymphedema. Here's an example of a lymphoscintigraphy image. Lymphoscintigraphy, when employed properly, can be a wonderful tool to help assess patients for lymphedema. In addition, preoperative indocyanine green, or ICG imaging, is also very valuable, and we have found it to be an extremely sensitive test, being able to pick up lymphedema even very early in patients with very early stages of lymphedema. This patient has a normal leg on their right side, which is the top side of the screen, and a more advanced affected leg on the bottom side of the screen. On the top, we can see that the channels are clearly delineated. Those lines are actually the lymphatic channels taking up the tracer dye. At the bottom of the screen, we can see that those channels are not clearly visible. In my experience, they're usually still present, but they're down underneath, they're possibly swollen shut, and that dye has leaked out into the lymphatic network under the skin. This is consistent with a clear diagnosis of lymphedema in this patient's left leg, again at the bottom of the screen. Some centers also use high-frequency ultrasound. We use this typically for preoperative planning, where we can actually often see the lymphatics directly with the ultrasound machine. We can also see the veins, and we can better plan out our surgeries and our incision sites. Some centers also employ a preoperative MRI scan to confirm the diagnosis of lymphedema. Here are some examples of lymphedema surgeries. Lymphedema surgeries are broadly broken down into two main categories. The first category is microsurgery or supramicrosurgery, with supramicrosurgery describing microsurgery performed on vessels that are 1 millimeter in diameter or smaller. They're typically more effective in patients with early stage disease or where there's a lot of fluid excess, meaning that the patient's arm or leg can be compressed or treated with conservative therapy to get that down, but requires continued conservative therapy to maintain that reduction. These types of surgeries include VLNT, which is vascularized lymph node transfer, LVA, or lymphaticovenous anastomosis, LNV, and lymph node to vein anastomosis. The second type of lymphedema surgeries are debulking or volume reduction surgeries. These involve the permanent removal of the deposits of fat and protein found in patients with advanced stage 2 or worse lymphedema. In these patients, permanent deposits of fat and protein driven by the lymphedema disease process have accumulated and can only be removed with more advanced surgeries. These include SAPL surgery, or suction-assisted protein lipectomy surgery, and CSAL, or circumferential suction-assisted protein lipectomy surgery. I'll start with examples of microsurgery and supramicrosurgery. These are surgeries performed in the operating room and require the use of a very specialized, high-power lymphedema operating microscope. The vessels and all the equipment are extremely tiny. Here's what a lymphaticovenous anastomosis, or LVA, looks like. This is a connection between the lymphatic and the vein. It is hand sewn with a super tiny suture under the specialized high-power microscope. We can see that one of these connections at the tip of the green arrow. Here's a ruler. This shows 1 millimeter increments, and we can see this same connection with a larger suture, much larger one. That's that black piece put into the lumen or the inside of the lymphatic so that it can be seen better for this image. Again, the needles are extremely tiny. The thread or suture material is much thinner than the diameter of a human hair. Back in 2005, I was visiting Dr. Koshima in Japan, and we made this slide. This is an example of some of the sutures we use. Here's a fine human hair. This happened to be my hair. Compared to the size of a tip of a standard ballpoint pen, the standard microsurgery needle and suture are right next to it on the left, and the lymphatic surgery needle and suture, which is even smaller, is one further over on the left. How do we identify lymphatics and veins under the microscope? We have multiple methods, including specialized optical filters and dyes and surgical experience. In this example, the veins, which are seen at the ends of the blue arrows, do not contain any of the specialized ICG dye or lymphozurin, which is a type of blue dye. In contrast, the lymphatics contain some of the blue dye in the filter seen on the left, and the same image under a different type of light filter shows the ICG on the right. Here we can see I am able to pick up the vein to better illustrate where we are going to attach the lymphatic once we divide the lymphatic and bring it up, attach it to the vein to provide an additional path of outflow and drainage for the lymph from this patient's leg. Here's the view of another lymphaticovenous anastomosis. In this case, the lymphatic is coming from the top and contains blue dye. At the bottom is a vein with a small vein side branch which extends upward. The connection has already been performed and hand sewn under the high-power microscope with the superfine suture. This is the direction of the lymphatic drainage. The anastomosis, or connection, is here. For me, it is very important to find one-way valves in the veins such that I'm connecting the lymphatics to small vein side branches that have valves present. That allows only the lymph to flow down and into the vein, but prevents the blood from flowing back out of the vein and into the lymphatic. This might ultimately result in a failure of the connection. We can see the lymphatic again coming from the top. That's the connection or anastomosis, and it's draining down into the vein below. Here's a closer view under the microscope as well. And here we can see the blue dye being pumped by the lymphatic system through the lymphatic. It goes through the anastomosis or connection and down into the vein. Once in the venous system, the lymph is taken and processed by the body to be able to be removed and filtered out. All lymph naturally eventually drains to the venous system. And again, by providing these connections, we can provide additional drainage to help drain that affected arm or leg. This is the direction of the lymphatic flow. Here we can see it again in blue. This is another view of the same vessel under the ICG filter. Here we can see the lymph, which is also carrying ICG dye, draining directly into the vein below. We see the lymph pulsing in and pushing down into the vein. Other surgeries that improve drainage of lymphatic fluid include vascularized lymph node transfer, or VLNT surgery. In this type of surgery, lymph nodes are taken from a part of the body where there's excess, such as the groin area. Lymph nodes can also be taken from inside the abdomen, for example, and they're transferred to an area that's affected by lymphedema. also performed using the high-power lymphedema specialized microscope. The results of the procedure can be quite dramatic and long-lasting. Here's a patient that I treated many years ago. On the right is her appearance prior to surgery, with the right arm being affected. And on the left, she's 11 years after surgery, with significantly decreased need for compression garment use or therapy. The other major group of lymphedema surgeries are debulking surgeries. As we described before, these include SAPL surgery and CSAL surgery. These surgeries have been around for a long time. SAPL surgery was first described in 1998, almost 30 years ago. Again, here we can effectively and permanently remove the solid deposits in chronic, solid predominant, stage 2 or worse lymphedema. In these patients, the lymphatic system has already sustained tremendous damage, and patients who are candidates have an affected arm or leg that never reduces in size to match the unaffected normal side. Here's an example of a patient with stage 2 lymphedema who would benefit from SAPL surgery. This is the same patient as seen with an MRI image, and the image allows us to see what a normal side should look like, in this case the patient's right side, where the deep tissues, which is the gray part in the middle, include bone, muscle, and blood vessels, and on top are some normal subcutaneous tissues, which are tissues under the skin, which include some fat. On the lymphedema affected side, the patient has much more volume, which is almost entirely composed of additional, permanent, affected, and inflamed lymphedema, fat, and proteins. There is some fluid also present within these. These account for a significant increase in the patient's volume. It's much harder for these patients to take care of their affected arm or leg, and they are much more severely affected than patients with stage 1 lymphedema. Here's an example of a SAPL surgery that I performed. Again, this surgery is performed in the hospital operating room. We borrow a tourniquet from the orthopedic surgeons, just as if the patient was having, for example, a knee surgery. I use a cannula, which is a long metal tube which allows me to aspirate or suction out the affected permanent proteins and fat. The way that the cannula is used is in the direction of the lymphatics, and we know that we are lymphatic sparing with this procedure, meaning that we protect the integrity and the continuity of the lymphatics themselves and also of the veins and the arteries. The amount of volume reduction we achieve is tremendous. In this case, the patient's pre-op or before surgery diameter is shown with the red arrow, and after surgery we expect this patient to get down to a much smaller diameter, such as can be seen by the green arrow. To make this work, lymphedema therapy is absolutely critical, in my opinion. This is an example of all of the bandages, and these are lymphedema specialized bandages, not just ACE wraps, that are required to wrap one leg in the operating room after surgery. Again, we absolutely emphasize a team-based approach, and the team is needed to bandage this leg. Both therapists and here our PAs are also helping. It's very important to understand that these types of advanced intensive debulking surgeries are not cosmetic liposuction. The procedure itself and the equipment used are very different. The cannulas are larger and less sharp to preserve those lymphatics and also be able to remove those very, very adherent, stiff, and inflamed lymphatic solids. Patients with lymphedema cannot clear normal postoperative swelling, such as that found in patients who are undergoing cosmetic liposuction. The cosmetic liposuction post-op care protocols are not sufficient and will not work well to take care of the lymphedema patients. Overall, the procedures require a different workup, again, a different procedure, different equipment, and different preoperative and postoperative care. And as I mentioned before, the team-based approach with an integrated lymphedema therapist or CLT is absolutely essential. Flat knit, which are custom compression garments specialized for lymphedema, are typically required both before and after lymphedema surgery. Basically, patients are not candidates if they're not already requiring flat knit custom compression garments to maintain their lymphedema systems. Flat knit custom compression is typically required both before and after lymphedema surgery. By definition, a patient needs to have advanced stage 2 or worse lymphedema in which these inflamed lymphatic solids are permanently deposited to be candidates for a SAPL surgery. We are not changing the need for the compression and the compression is still required after surgery as it is before. What we are doing is tremendously decreasing that extra volume of those really adherent and pathologic lymphedema solids to allow healing to occur and to allow the patients to be able to drain better after surgery. Here's an example of the cosmetic liposuction aspirate, or the material that we get out after cosmetic surgery. So it's relatively smooth, it's more creamy, more light in color, and it's more uniform. In contrast, the material that comes out after lymphedema surgery or debulking surgery looks more like curdled milk. It's thicker, it's much tougher to get out, and it's much more heterogeneous or lumpy inside because the tissues that we're removing are so much more inflamed and advanced, and they're quite different. The volumes that we aspirate out of patients with lymphedema are also much higher. In this case, all of these canisters came out of the leg of one patient, and each canister contains probably more material than a 2-liter or 2,000 cc soda bottle. I'd like to illustrate the sample surgery technique with a case study. Here's a patient with advanced lymphedema in both legs. She's a very severe case, and she's stage 2 on both sides. In fact, she's had treatment before with surgery performed elsewhere on the right side, which has produced these significant scars in the right lower leg. We performed sample surgery first on the patient's left leg. After approximately 4 hours of surgery, this is how her leg looked in the operating room. These are photos of the aspirate or material that we removed from the patient's left leg only. The total volume that we got out was over 6,900 cc's. To put in perspective how much that is, again, 2,000 cc's is the equivalent of a 2-liter soda bottle that can be bought at a convenience store. So in this patient, we removed almost 3.5 bottles worth of lymphedema solids. Here she is before surgery, and here she is 4 months after her first surgery. Subsequently, we went back and did the sample surgery also for the patient's right leg. Again, approximately 4 hours of surgery in the operating room. This is how she looked on the operating room table following surgery. And here are some photos of the aspirate from that patient's right leg. We took out approximately 5,000 cc's, again, over 2.5 2-liter soda bottles worth of material. Here's how she looked before her surgeries, and here's how she looked when she's maintaining her volume reductions over 2 years and 9 months after the sample surgeries. It's important to note that the lymphatics are not damaged by sample surgery performed by an experienced surgeon. This is how the imaging might look for a patient with advanced stage 2 lymphedema before sample surgery. And here are the images of the same patient's legs after the sample surgeries, which are unchanged from before surgery. Now, as an aside, we can also perform LVAs or go back and perform a microsurgery or super microsurgery once the patient is healed from the sample surgery to further allow drainage from the leg to reduce the amount of compression needed to maintain their new volume reductions as a second phase surgery. Again, patients who have undergone sample surgery are usually candidates later for subsequent microsurgery such as an LVA surgery. In this case, we can see the lymphaticovenous anastomosis. Again, the lymphatic is draining some of the blue-green dye or lymphozurin. Under a different filter, we can see the ICG draining from the lymphatic through the hand-sewn anastomosis and around into the vein. This reduces the amount of compression and therapy needed after the sample surgery for the long term. Combined surgeries for lymphedema. As I alluded to before, surgeries and surgery types may be staged or combined in patients to improve their overall outcomes. Again, as with all types of lymphedema surgery, we feel very strongly that conservative therapy should be maximized first to address any excess lymphedema fluid present. In my opinion, debulking and sample surgery is then performed to address the solid predominant excess first. I'd like to get rid of all those excess solids that are causing inflammation, holding on to that inflammatory fluid. What I do is then reduce the volume of that patient's arm or leg to get it back to the size of the unaffected normal side. We allow that arm or leg to heal, and then we maintain that volume reduction using an LVA or VLNT surgery at a later time to decrease the amount of therapy and compression needed long term. Again, different surgeons and different centers will have different approaches and different protocols. Here's an example of a patient who had lymphedema on the left arm following breast cancer treatment. She had stage 2 lymphedema, in which she had solids present, and that affected left arm never reduced in volume to the size of her right arm. Sapple surgery, followed by a lymph node transfer, were performed, and here she is many years later, not wearing or requiring the compression garment to be used during the day. Here's an example of another patient. Again, she had lymphedema of the right arm this time following breast cancer treatment. Stage 2, which means solids were present, and that right arm never decreased in volume to the size of the left side. And here she is following Sapple surgery with VLNT or lymph node transfer surgery at a later time. She had a 98% volume reduction, and she did not require the use of garment for over 8 hours each day. Another patient, again an arm, following breast cancer with an advanced stage 2 solid predominant lymphedema. Sapple surgery reduced her volume by approximately 95%, and the lymph node transfer allowed us to come off with that garment use or reduce the need for the garment by over 12 hours each day. Here's a different example with a patient with lymphedema of the right leg. Again, she had advanced stage 2 lymphedema with a lot of solids, including fat and proteins, that were not allowing that right leg to ever go down in size to match the left leg. Sapple surgery allowed us to reduce the volume, in this case by 109%, meaning that that affected leg actually ended up slightly smaller than the unaffected side. The VLNT and LVA surgeries were then performed once healing from the sapple was complete and significantly reduced the amount of compression and therapy required to maintain that leg volume. I'll finish with some frequently asked questions. The first question is, which treatment option is best for you? This will vary patient to patient. The lymphedema disease process and condition is different in each patient. Different surgeons and different centers will have different training and experience, and these differences will result in different treatment recommendations from surgeon to surgeon and center to center. Next, is congenital lymphedema more difficult to treat? Yes, patients with congenital lymphedema tend to be more difficult to treat. However, patients, in my experience, with congenital stage 2 lymphedema do just as well with their volume reductions after a Sapple surgery. Final frequently asked question, what is the difference between lymphedema and lipedema? Both these conditions sound similar. However, they're extremely different. Lymphedema is a disorder of the lymphatic system. It's usually unilateral, meaning one side is almost always different or worse than the other. It involves pressure rather than pain, and infections and cellulitis are extremely common and debilitating. Lipedema, on the other hand, is a disorder of pathologic fat and connective tissue. The fat cells of lipedema seem to be programmed differently and tend to be more inflammatory and cause more problems than unaffected fat cells. In this disorder, legs are usually affected more than arms, and it's usually bilateral or symmetric on both sides. This disorder is often very painful, and even light touch or light pressure on the affected areas can cause significant pain. It's usually associated with female hormonal changes, and patients can be especially emotional. Now, the clinical appearance of lipedema and lymphedema can overlap, and patients can have both lymphedema and lipedema present, such as found in these patients here. Thank you very much for sharing your time with me here. If you have any further questions, please refer to the NLN website for further information.